some hope started to of immunotherapy, which turned out after a while, and it seems that nothing much is really happening. And lately, this is really about this event. It's about, and will be joining us today, a very strong faculty from many universities in Egypt and from outside of Egypt, though Professor Rafat, and today we're gonna, and actually we thought about doing like 2 events with bladder cancer as Casual Club, and one of them is gonna be a physical event on Thursday, and one of them is a virtual event, which we are on today. And people might ask, we kept it on 2 separate events because basically on Thursday it's going to be about case scenarios and situation like that. And I believe that the trials, the key studies, will not be fully of being fully discussed. So I thought that this would be a good opportunity for us to discuss the key trials that have appeared in this recent time, and we're gonna see how is it practice changing or not. So I will not delay our participants anymore, so we can start with the first speaker. The first speaker is a very, very close friend of me, though we didn't see each other for a while. He is Professor Rafat Ragai. He's Professor of Oncology, and I say that Cairo University first, and also, of course, is a consultant of clinical oncology in the UK. I will let him introduce his post, and he's gonna give us initially, before we deep dive, an overview of treatments in bladder cancer, urothelial cancers, so we'll have context in whatever clinical trials we're gonna discuss. So, Professor Rafat, we are all listening and waiting.
Thank you so much, Shamr. Can you hear me well?
Perfect.
Shall I share my screen? So good afternoon, everybody. Thank you so much, Shamr, for the opportunity to be among my dear colleagues from Egypt. And I'm happy to have this opportunity. So what I'll be discussing in the next 20 minutes is an overview of the role of systemic therapy in urothelial cancer. So first, to begin, as we all know that treatment is based on staging, and urothelial cancer has a specific, so it follows the TNM staging, but we can divide it further to early non-invasive bladder or urothelial cancer, which includes the TA, TIS, and T1, okay? And then the muscle-invasive early bladder cancer with the node-negative stage 2, okay, the T2 and 0, and then the locally advanced, and lastly, the metastatic cases. So first, regarding the stage 0 or 1, which is the non-muscle invasive bladder cancer, we further classify these types of patients according to the risk, okay? And as you can see from this table, the patient can have a low risk, intermediate risk, and high risk. So the low risk cancers are those with having papillary urothelial neoplasms, low malignant potential, or low-grade urothelial carcinoma with TA less than 3 centimeter and solitary. But if they have a different, so T1 or more than 3 centimeter or multifocal, they are intermediate risk. And if they are high grade and not low grade, but with a TA less than 3 centimeter and solitary, they still intermediate risk. And those patients with intermediate risk are offered intravesical BCG vaccine, okay? And then they can also be offered surveillance, although the preferred option will be the BCG vaccine. Then we have the high risk patients who have CIS, T1, more than 3 centimeters or multifocal high-grade cancers, and those patients can be offered intravesical BCG or cystectomy, while if they are very high-risk features, including those who had previously received BCG and was unresponsive, or have a different histologist, or more urethral invasion or lymphovascular invasion, the preferred option would be cystectomy. But recently, pembrolizumab was included in the treatment algorithm for this patient. So pembrolizumab is based on the Keynote 057, which included patients, about 96 patients, are given pembrolizumab every 3 weeks for up to 2 years. And if you can see from the
recording in progress,
the slide here, that about 41% can achieve a complete response, and this response can last for more than a year. So it's a very good achievement with the introduction of immunotherapy. So although the BCG is a form of immunotherapy, but nowadays the immune checkpoint inhibitors are becoming more and more popular. So moving to the stage 2, which is a clinical T2 and 0, we have a few options. The main option or the standard of care for these patients are neoadjuvant cisplatin-based chemotherapy followed by cystectomy. For those who are not eligible to receive cisplatin, they can offer cystectomy alone. And for those who prefer a bladder preservation approach, they can offer a maximum tumor resection through cystectomy, cystoscopy, followed by radical radiotherapy concurrent with cisplatin or 5-FU mitomycin C, and this can be delivered for those who are not eligible for cisplatin as a better option compared to radiotherapy alone. But if the patient is not candidate neither for cystectomy or definitive chemoradiotherapy, they can be offered either TURBT or palliative radiotherapy. So on what basis do we have this neoadjuvant? This was based on a phase 3 study which compares cystectomy alone with the old chemotherapy regimen, the MVAC, followed by cystectomy. As we can see in this graph, okay, that the survival for those patients with chemotherapy prior to cystectomy has increased from 46 months to more than 70 months. And more recently, the studies using the dose-dense MVAC compared to cisplatin gemcitabine, the 10-year survival of this study did show that a bit of improvement of progression-free survival if you're using the dose-dense MVAC compared to gemcitabine cisplatin. Then we have the option for those patients who are not eligible for cisplatin. They can be offered 5-FU mitomycin C, a regimen similar to the one used for anal cancers. And this study, which is the BC 2001 trial with 10-year follow-up, did show that the addition of chemotherapy regimen, which is the 5-FU mitomycin, improve the local control as well as progression-free survival and bladder cancer-specific survival in comparison to radiotherapy alone. So if your patient is not eligible for cisplatin, then it's better to offer him or her 5-FU mitomycin, which is evidence-based compared to carboplatin, which was used by some centers. Then what about those who have cystectomy? Is there any benefit from adjuvant treatment? Those who didn't receive neoadjuvant chemotherapy, they should be offered adjuvant cisplatin-based chemotherapy. Okay, and those who had the neoadjuvant chemotherapy, they can be offered adjuvant immunotherapy. And this is a recent approval based on the CheckMate study, which had shown that we'll be discussing in the next slide. The CheckMate 274 did show an improvement in the intention to treat population in the disease-free survival, nearly doubled compared to cystectomy alone, or even for those who had neoadjuvant chemotherapy. So the addition of immunotherapy did benefit the disease-free survival, although there is no overall survival data published yet. And this is why there could be a debate about the benefit of this study. But if we look in a bit in depth, we can see that those who had the PD-L1 more than 1% are the main group who benefited from the addition of nivolumab compared to placebo in this group. And if we look to the forest plot, we can see that the main benefits are for node positive and for those who are PD-L1 positive. And this is why the NICE did approve the adjuvant nivolumab only for those who are PD-L1 positive and had YPT2 to 4A or YPTN positive only, while the study included also PD-L1 negative patient, but the benefit is more obvious and restricted to the PD-L1 positive. So moving to another immunotherapy, which is atezolizumab. Okay, the atezolizumab was tried in the IMvigor study of 10, which didn't show any benefit of addition of atezolizumab compared to placebo for those patients following cystectomy. And this is why this agent is not approved in this setting. So moving to the locally advanced stage 3A, okay, which includes the clinically T3 and 4A or not positive, the main benefit is from neoadjuvant cisplatin-based combination chemotherapy followed by radical cystectomy and then adjuvant nivolumab, as we discussed in the previous slides. Also, cystectomy alone could be offered for those patients who are not able to receive chemotherapy, neither neoadjuvant adjuvant, and those who are not candidates for cystectomy, they can offer definitive chemoradiotherapy or even radiotherapy on its own. Moving to more advanced cases, which is the stage 3B, including the N2 and 3 or the T4B without any metastasis, those are more or less treated like metastatic cases. So they are offered systemic treatment for 3 to 4 cycles. If they respond, then they can be treated as the stage 3A with surgery or radical chemoradiotherapy. If not responding, then the option will be moving to a second line systemic treatment, as we'll be discussing later. And for those who are not fit for chemotherapy, then the only option available will be concurrent chemoradiotherapy or radiotherapy on its own. So what about the metastatic patients who are metastatic at presentation? The treatment option until 4 years ago was in first line cisplatin with gemcitabine or even carboplatin. And for a second line treatment, single agent chemotherapy with taxanes or venflunine. So the taxanes in the second line was, there was a single arm study which showed a benefit of about 7 months, okay, from taxane in second line, okay. And if we look to the venflunine study, which was a phase 3 study compared to best supportive care, although it's published more than 10 years ago, it showed that the median survival is also 7 months, okay. But when they look to the toxicity and compare it to the taxanes, venflunine was not in favorable of venflunine, and this is why the NICE didn't recommend venflunine for those patients. And then recently, we got the immune checkpoint inhibitor. So it first started in the second line with the Keynote 045, and it showed still we have 7 months from chemotherapy, which improved to 10 months. So 3 months addition in the overall survival benefit with immunotherapy. And this benefit is more obvious for those who had more than 3 months from the chemotherapy. So a bit of a responsive rather compared to those who are refractory disease, so less than 3 months from the chemotherapy. And also it was better seen with those with CPS score more than 1% compared to who are negative. So the immunotherapy can be offered in second line for those who didn't receive it in the first line, especially for those who had more than 3 months of benefit from chemotherapy and with a positive CPS score. What about nivolumab? Nivolumab was also studied in the Checkmate 275, and it showed for those who had are PD-L1 positive a good improvement in survival. Any other options for this cohort of in second line? Yes, we have the SOURCE study, which is targeted therapy, which is using an erdafitinib versus chemotherapy in those patients with FGFR alteration, which this constituted about 20% of patients, and it showed more or less improvement in survival about 4 months compared to chemotherapy, which is still in the range of 7 months. So from the previous few studies, we can see that the second line has improved survival from 7 months from the standard chemotherapy to allow to about 11 or 12 months with either target therapy for those who are positive for FGFR or PD-L1 positive with immune checkpoint inhibitors. And then there was the cohort 2 of this study, which I wouldn't go into detail because this will be discussed later by Dr. Abdel Hamid. They compared the target therapy with immunotherapy. So I leave this to Dr. Abdel Hamid to discuss further later in this evening. So what about the antibody drug conjugates? Okay, is there any place for this category, new category, which included in many cancers, in bladder cancer? Yes. So enfortumab vedotin was used and was compared to chemotherapy in this setting, and it showed similar benefit. So we can see that we still around the 8 months benefit from chemotherapy, and this new agent give us about 12 months of overall survival. So still another option we can offer in those patients. So moving to the first line, so for those who are not eligible for cisplatin, where first have nothing to offer apart from taxanes, then we got the immune checkpoint inhibitor in those patients who are cisplatin ineligible, and it was a phase 2 study, a single arm study, showing a median survival of 11 months, the Keynote 052, and this benefit, which was much better improvement in the CPS more than 10 compared to CPS less than 10. So those patients benefited more from the immune checkpoint inhibitor. Any other drugs? The atezolizumab was studied, okay, although there was no benefit according to the PD-L1 scoring. So PD-L1 negative were benefiting similar to the PD-L1 positive. Moving to the cisplatin eligible, as we mentioned, the standard of care was cisplatin or carboplatin with gemcitabine. So what about the addition of immune checkpoint inhibitor in this setting? There was a slight improvement with the addition of immune checkpoint inhibitor, although this improvement was not seen regardless of the PD-L1. So based on this, the pembrolizumab was not attractive for those patients. Atezo was also used, and similar slightly improvement in the progression-free survival and overall survival, with a hazard ratio of 0.83 and p-value of 0.027, and the median survival has improved from about 13 months to 16 months. So a 3 months improvement in overall survival with the addition of immune checkpoint inhibitor to chemotherapy. So what about immune checkpoint inhibitor on its own in compared to chemotherapy? Still, there is a benefit in those tumor with PD-L1 positive, but this benefit was not seen in those who are PD-L1 negative. So moving to another study, which was the addition of maintenance immunotherapy to the standard chemotherapy. And this is a Javelin Bladder 100 study, which will be discussed by Professor Ahmad Ali in the next session. It showed a good improvement in overall survival. You can see that we're now crossing the year till nearly 21 months. So this improvement was in the overall population. If you look to the PD-L1 positive, it was a significant improvement from 17 months till this median was not reached in the study. So what about other checkpoint inhibitor? We discussed pembrolizumab, which was not that attractive, but nivolumab showed a better response with chemotherapy compared to chemotherapy alone. So we're now moving from the 18 months till the 21 months, which is similar to the Javelin study. So immunotherapy, while it's given as a maintenance or with chemotherapy, can improve overall survival. What about the antibody drug conjugates? So this study, which is a keynote 39, which will be discussed as well by Dr. Hazem, it showed that the antibody drug conjugates can improve survival in compared to immune checkpoint inhibitors. So we're now moving from the 16 months till the 31 months. And this was similar benefit whether the patient is eligible for cisplatin or not. So my conclusion for this presentation is the first-line treatment option in 2023 has significantly improved compared to back in 2019. So now we have the gemcitabine cisplatin followed by maintenance avelumab, which is a Javelin Bladder 100 study. And then we have the immune checkpoint inhibitor added to the chemotherapy, which is the Checkmate 901, or the combination of immune checkpoint inhibitor and antibody drug conjugate, which is the Keynote 39. So I will stop there, and I think the next few presentations will be discussing these studies in detail. Thank you so much for your attention.
Thank you, Professor Rafat. That was a very rich and very comprehensive presentation, the overview of systemic treatments in urothelial cancers. Really, as Professor Rafat have showed, it's quite changing, and I guess Professor Rafat a few years was much simpler than that. For the declaration that even in European countries is availability homogeneous. So it's very normal that you find like erdafitinib in Egypt, and you cannot find it in Denmark, for example. You cannot find erdafitinib. Potentially with Astellas, we will have in Egypt before they have it in
the UK.
Clearly, so for the first, we're going ahead in regarding the urothelial cancer, we're getting some points here. And I observed in your presentation observation where we see like other different cancers where you have a differential checkpoint inhibitor. So clearly the anti-PD-1s are not like the anti-PD-L1s, as a repetitive of inefficiency with atezolizumab, for example. So it's not absolute. However, it seems that it's brothers, or whatever you can call them, Nivo and Pembro, they get quite a benefit. So do you have a comment about that? So the checkpoint inhibitor agents
definitely they are not. There is it's not only in urothelial cancer but other cancers. So they the responses, and I don't think it's depending on the. So maybe we need to have that we're using to patient to a specific medication with her, because using the current PD-L1 testing for everyone is not are the right test for each medication. So I think this is one of the points.
Yes, definitely. So I would like to, I guess we can proceed for the maintenance immuno. So we are gonna. I'm happy to invite Obeya. He's professor of clinical oncology at the Azit University. He's gonna give us his talk or his angle of the Javelin Bladder 100 study of avelumab maintenance after first-line chemotherapy in advanced urothelial cancers. Please, Professor Ahmed, go ahead.
Thank you, Dr. Amr, for your invitation and introduction, and thank you to Rafat for your presentation. I am happy for this great faculty today for this important topic with rapidly evolving results of landmark trials that we discuss today. One of them is the Javelin, and the first of them is the Javelin Bladder 100 in testing the hypothesis of the role of maintenance immunotherapy after control of the disease of metastatic disease by first-line chemotherapy. And I will highlight some data from systemic treatment. This is the cross-sectional survey for 150 oncologists in the US in 2021 about the rate of treatment of patient in upfront or de novo metastatic urothelial carcinoma, and the survey showed that only 70% of patients with first diagnosis of urothelial cancer candidate for treatment for many reasons. One of them is poor performance status or patient refusal or the age, advanced age of the patient or comorbidity. So if we diagnose patient with urothelial carcinoma, about only 70% of them will receive first-line treatment. And on progression of first-line treatment, only 10 to 30% of those patients progressed on first-line treatment are candidate or can tolerate second-line treatment. So we need to optimize the result of first-line treatment as much as possible in order, because a lot of patients progressing after first line will not tolerate second line. And as you know, the standard of care for the first line treatment is the platinum-based chemotherapy for platinum-eligible patient. And as you see from previous trials, about 80% of patients receiving platinum-based chemotherapy will take a clinical benefit or response rates from this platinum-based chemotherapy. But unfortunately, as you know, also, we can't maintain chemotherapy for a long period. We only give 6 cycles or less from platinum-based chemotherapy because we have no data about the clinical benefit after 6 cycles, and we have cumulative toxicity, especially from platinum treatment. So how we maintain this great benefit achieved by platinum chemotherapy? If we look for the data mentioned by Dr. Rafat from this phase 3 trial, we will focus on the control group of this trial with chemotherapy only, carboplatin or cisplatin gemcitabine. And as you see, the progression-free survival for this platinum-based chemotherapy is around 6 to 8 months, and overall survival is around 14 months, which is much less in patient with poor prognostic factor like poor performance status or patient with visceral disease. That's why this patient received only 6 cycles of chemotherapy and then kept on best supportive treatment and surveillance. So can we maintain the benefit from chemotherapy by using something in the maintenance or after chemotherapy to maintain the disease control achieved by chemotherapy? This is a watch and wait approach before the Javelin trial result. And after chemotherapy, if we use an active drug, we can push the second line treatment, and so we can prolong progression-free survival and subsequently overall survival. This is a maintenance approach. What we use or what we can use in the first line maintenance treatment, the logic is to use one of the agents used in the second line treatment, which is active after disease progression. And as you know, several factors contribute to the biological rationale for the benefit of immune checkpoint inhibitor maintenance therapy in urothelial carcinoma. One of them is tumor-related factor. We have data that the bladder cancer is immunogenic tumor with high mutational burden and the high genomic instability. So have a great activity, immunotherapy have a great activity in this disease area. And also we have chemotherapy-related factors. chemotherapy induce the new antigens by cancer cell destruction. Also, chemotherapy can decrease the disease burden, and we have data that immunotherapy is more effective in patients with less disease burden. So the cytotoxic and immunogenic effect of platinum-based chemotherapy provides the opportunity to enhance the clinical efficacy with immune checkpoint inhibitor therapy. And this is the idea or the hypothesis of Javelin trial. This is the design of Javelin trial. This is international phase 3 trial. The hypothesis is a maintenance avelumab after first line chemotherapy, platinum-based chemotherapy. So we include a patient with unresectable, locally advanced metastatic urothelial carcinoma stage 4 disease or locally advanced unresectable. And those patients receive 4 to 6 cycles of platinum, cisplatin or carboplatin plus gemcitabine. And after that, we assess the patient for response. So we have treatment-free interval 4 to 10 weeks. Then we assess the response and include for randomization only patient with clinical benefit from platinum-based chemotherapy, either complete response, partial response, or stationary disease. So we have now 700 patients. Those patients randomized to either avelumab 10 milligram per kg every 2 weeks plus best supportive care versus watch and wait, best supportive care only. So we have active treatment arm and the control arm. And then the primary endpoint for this trial was overall survival, stratified as all randomized patient and then for PD-L1 positive patient. And we will assess the overall survival from randomization, and we have data also from the start of chemotherapy. The second endpoint is progression-free survival. This is a patient characteristic, as you see, is well balanced between both arm, treatment arm with avelumab and the control arm with best supportive care. Especially, we should focus on some patient characteristic with poor prognosis, like patient with visceral metastasis, well balanced between both groups, and patient with a stationary disease after platinum-based chemotherapy, of course, not have the same prognosis the same as patient achieve complete or partial response after chemotherapy. And we will focus also on PD-L1 positivity, which is well balanced between both groups, as you see. This is a primary endpoint. As you see, it was a positive trial. Avelumab first-line maintenance after chemotherapy control of the disease significantly prolonged overall survival in all patients compared with best supportive care alone. And so the primary endpoint was met in this trial. And as you see, we have more than 7 months improvement in overall survival with a hazard ratio of 0.76. So we have 24% risk reduction of this in avelumab arm. We have 50% of patients, as you see, after 2 years, still alive versus 38% in the control arm. Of course, you should also focus on initial part of the curve. The separation start early, so and maintained benefit for the avelumab. This means that patient with, as we will mention later on, patient with chemotherapy arm only receive immune checkpoint inhibitor on progression, and that's also, despite this protocol, the overall survival is still positive and improvement. This means that you should use immune checkpoint inhibitor early after chemotherapy, better than using immune checkpoint inhibitor after progression on chemotherapy in the second line setting. Also, if we assess the overall survival from the start of chemotherapy before randomization, we have now overall survival, like Dr. Rafat mentioned, around 30 months versus 20 months for chemotherapy with hazard ratio 0.77. And this overall survival is more prominent in patients with PD-L1 positive disease more than in overall population, as you see, and not reached versus 17 months in the control arm. The hazard ratio now is 0.5 versus, as we mentioned before, in the intention to treat populations, the hazard ratio is 0.77. Also, if we look for the PD-L1 negative patient median overall survival, 18 months versus 13 months in the first assessment, first analysis, with the hazard ratio much less than patient with PD-L1 positive disease, but still significant for PD-L1 negative population. If we look for the secondary endpoint, progression-free survival also was positive. We have a good separation of the curve, as you see, and median progression-free survival 5.5 months versus 2.1, with the hazard ratio 0.54. So avelumab as a maintenance treatment decreased the risk of progression by 46%, as you see. Also, this progression-free survival benefit was maintained in all pre-specified subgroups. Also, all pre-specified subgroups showed improvement in the overall survival, either irrespective of the patient age of the PD-L1 positivity or negativity. But we will focus, as we mentioned, on patient based on the response of the chemotherapy. For patient achieving complete or partial response, as you see, the benefit is much higher, but still positive for patient with a stationary disease. But this point should be kept in mind when you evaluate different drugs, different protocol in your clinical practice. Also look for the patient with visceral disease versus patient with non-visceral disease. The benefit is much for or more for non-visceral disease. Also in patient with PD-L1 positive versus patient with PD-L1 negative disease, despite that both are positive significantly statistically, but you should keep in mind what is comparing different protocols. Regarding the type of chemotherapy used in the first-line treatment, the benefit for overall survival and progression-free survival with the addition of avelumab is maintained. Either you used cisplatin or carboplatin, because we have data previously from historical trials for chemotherapy that cisplatin is more effective than carboplatin. But as you see, the benefit is maintained for patients with cisplatin or patient received carboplatin in the first-line setting. Of course, again, we assess the clinical benefit from adding avelumab based on type of response to initial chemotherapy. You see the benefit is maintained either the patient achieved complete response, partial response, or a stationary disease. But there is difference in the magnitude of benefit, and we need to initiate further trials with each response to evaluate the cost benefit for this effective and positive treatment in every type of response. Even in patients who had complete response with first-line chemotherapy, median progression-free survival in the best supportive care alone arm was 5.1 months, as we mentioned, highlighting that the complete response with first-line chemotherapy doesn't provide durable benefit for the majority of patients. In this subgroup, the risk of disease progression or death was reduced by 42% in avelumab arm. So despite the patient achieving complete response, but in avelumab arm is much better than in the control arm, either in the overall survival and progression-free survival. As we mentioned before, if you test the drug, what is the effectiveness of this drug versus a control drug, you should look what the control group receive after progression in order to assess the overall survival. So if we look for the chemotherapy, then best supportive care, we found, which is the control arm, we found that 61% of patients in the best supportive care control arm receiving subsequent therapy after progression, after chemotherapy. 43% of them receiving immune checkpoint inhibitors. So all population didn't receive avelumab in the control arm. 43% of them receive immune checkpoint inhibitor on progression. And despite that, the overall survival is better with avelumab arm. This means that initiation of immunotherapy early after chemotherapy as a maintenance therapy is better than waiting for using immunotherapy in the second line setting on progression. Also regarding the adverse event and side effect, as we mentioned before, the Javelin trial protocol didn't limit the number of cycles of avelumab. So avelumab was used until progression. And despite this long-term treatment, there is no long-term safety signals for avelumab first-line maintenance and this long-term data, as you see, consistent with the earlier analysis, and all side effect was manageable, and only 11% of patients will discontinue treatment due to adverse event from avelumab, which is manageable and have high safety drug. Javelin 100, Bladder 100 was the only phase trial before last ESMO, only phase 3 trial of first-line immune checkpoint inhibitor treatment for advanced urothelial cancer that has shown statistically significant overall survival, as you see, despite we have 2 large phase 3 trial using immunotherapy combination with chemo followed by maintenance immuno is the continuation maintenance like Invigor 130 and Keynote 361. And despite that, these 2 trials was negative, I think that's because these 2 trials, including patient refractory to chemotherapy, but Javelin excluding patient refractory to chemotherapy or progressing or chemotherapy. Also, these trials, especially Keynote 361, allowing patient with chemotherapy arm only to cross over to Pembro on progression. So this is a guideline after the Javelin trial changed, and patient with cisplatin eligible or cisplatin ineligible but platinum eligible can receive avelumab after control of the disease with chemotherapy as a maintenance treatment. And this is avelumab first-line maintenance treatment can be tailored according to practical consideration in your clinical practice and the patient needs. Patient with first-line chemotherapy regimen, overall survival in Javelin trial in patient who had received either cisplatin or carboplatin based first-line chemotherapy is equal overall survival hazard ratio for cisplatin of 0.78 or 0.74 carboplatin. Also, regarding the duration of first-line chemotherapy, some patients using 4 cycles and some patients receiving 6 cycles. And as you see, for the hazard ratio, there is no difference in patient receiving 4 cycles or 6 cycles. Also, according to the response to the first-line treatment, we have much more clinical benefit for patient achieving complete response or partial response, and less benefit for patient with a stationary disease, but still significant benefit. What about the interval from the end of chemotherapy to the start of maintenance? We have in the protocol 4 to 10 weeks to start immunotherapy, and no difference for patient starting early or at 10 weeks regarding the overall survival, as you see the hazard ratio. So this is a guideline now. Cisplatin, carboplatin, which is a standard of care in the first-line setting containing regimen. If the patient controlled based on the Javelin trial, we can maintain them with avelumab immune checkpoint inhibitor, and so we have multiple options in the subsequent treatment, as you see, drug conjugate enfortumab or sacituzumab, or target therapy FGFR inhibitor erdafitinib or platinum if long period of previous chemotherapy treatment-free interval, and other option in the third-line setting. We have now open question regarding the Javelin trial. We have 20% of patients progressing on chemotherapy and excluded from Javelin trial protocol, and this I think this is need discussion for Javelin trial. Yeah, this is very important. Also, we have clinical benefit in patients with visceral metastasis should be discussed. What's better for the 3 landmark trials discussed today to start with for those population with visceral metastasis, for those population with PD-L1 negative, for those population with stationary disease after chemotherapy, what's better to use maintenance protocol or combination drug conjugate plus immunotherapy protocol. We need exploratory analysis for patient in control arm who receive subsequent immunotherapy on progression. So we need to isolate those population to start immunotherapy on progression, and the patient didn't receive immunotherapy because there is contamination in the data from those population. Subgroup analysis also needed for clinical benefit in patient with FGFR alteration at the baseline. Those population respond to immunotherapy as a maintenance or no difference with immuno versus best supportive care in those population. Thank you.
Thank you, Professor Ahmed. This was a very strong presentation, and I guess لو وقفنا الايفنت عند هنا هيبقى خلاص واضح ان we should use abilimumab as a maintenance. However, we have still studies to discuss, because basically at the last ESMO a lot of data came up. I thank you for the last slide, because in spite of being very passionate about the study data, and you have the right to do so, you put a lot of very good questions that we will discuss actually all together in trying to see if these studies are practice changing or not. So I guess for now, proceed to our next speaker. So I would like to introduce Professor Yasser Al-Qurb, Professor of Clinical Oncology, Alexandria University. He's gonna discuss a very interesting study, the Checkmate study, which is finally a successful immunochemotherapy combination in first-line advanced urothelial cancer. So finally, Dr. Yasser, a study that's positive. One reminder for our participant and audience, if they want to give any questions, so please write it in the chat, and I will try to answer it all. So, Professor Yasser, go ahead.
Okay, thank you so much, Dr. Amr. Do you hear me well?
Yes, okay. Very well.
I'll share my slide. Okay, thank you so much, Dr. Amr, for your kind invitation. I'm so happy to join the Kaiser Cup group for sending me the slides of this. Today, I'm going to present the data of the Checkmate 901 that was released in the. And before I go in, as we heard before, that patient is unresectable or metastatic urothelial carcinoma, cisplatin or carboplatin-based chemotherapy, if they are platinum eligible, with a response rate of like 40% and median overall survival of 15 months. Then in 20, Dr. Ahmed said the Javelin 100 trials came with the addition of maintenance immune therapy that improved the median overall survival from 15 months to like near 22 months by using the abilimumab. But no novel agent has improved overall survival when concurrently to platinum-based chemotherapy. So I will report on this final result of the Checkmate 901 using Nivo as checkpoint inhibitor plus the standard chemotherapy, gemcitabine, cisplatin in metastatic urothelial cancer. This trial randomized more than 600 patients with previously untreated, unresectable metastatic urothelial carcinoma, involving also patients with the renal, pelvis, ureter, bladder, or urethra. Of course, they are all cisplatin eligible. All patients in this trial received cisplatin only. Carboplatin was not used, and with performance status equal 0 to 1. Arm A was the Nivo plus the standard of care gemcitabine cisplatin versus chemotherapy alone, gem-cis. And for the Arm A, Nivo was giving in maintenance until there is disease progression or an unacceptable toxicity or maximum up to 24 months. And certification factors for this trial was based on the tumor PD-L1 expression, either negative less than 1 or positive 1 or more, and liver metastasis presence yes or no. The primary endpoint of this trial was the overall survival and survival, with secondary endpoint and was the overall survival and progression-free survival by the PD-L1 and health-related quality of life. This is the two groups. We can see that they are equally balanced, and we can see that patient with tumor PD-L1 positive represent 1/3 almost of the patient in both arms, while liver mets was seen in 20% of patients also in both arms. This is the median duration of the study therapy. It was 7.4 months in nivo arm versus 3.7 months in the chemotherapy arm, and about 75 patients completed 6 cycles of treatment in the nivo arm, while 55 only in the chemotherapy arm completed cycles of chemotherapy. Here also the overall survival, which is the primary endpoint, we can see that the curves are nicely separated, favoring the addition of nivolumab to standard chemotherapy gemcitabine. And we can see at 24 months or 2 years, 46.9% of patients were alive versus 40.7%, with a median overall survival of 21.7 months versus 18.9 months for the chemo alone. And this value was statistically significant. We can look at the forest plot here to subgroups. You can see that the response or overall survival was all in favor of the nivo arm group. Even if you can see those for liver mets or for PD-L1, whether positive or negative, or are in favor of the nivo plus chemotherapy. I don't know, here is the only one of the group in US region. I don't have explanation, but maybe the small number of patients that make this group only go in favor of chemotherapy arm. And this is the primary progression-free survival. We can see here the curves are also nicely separated with median progression-free survival for the nivo arm 7.9 months versus 7.6 months for the chemo group. You can see the difference is not so big, but if you look statistically, the p-value is statistically significant. This is also the forest plot subgroups for the PFS. The PFS was better in favor of the nivo chemo arm for all subtypes of patients, also including those with PD-L1 expression and liver mets. Here is the progression-free survival controlled by the BICR sensitivity analysis. We know that the BICR, or what we call blind independent central review, they use strict criteria for assessing the patient, so that they censored the patient who received treatment after finishing the chemotherapy in the control arm. And during this study, the javelin was approved, and many patients in the arm of chemotherapy received maintenance evolumab after chemotherapy, and those represent like 20% of the population. That's why the sensitivity analysis patient receiving subsequent anti-cancer therapy diagnosis was not censored and was calculated in the trial. And we can see here the curves are still separated in favor of nivo arm with 7.9 months PFS versus 7.5 with statistically significant value. This is the objective response outcomes. We can see that 57% of patients in the nivo arm showed response, with 21.7% complete response versus 43 in the control arm of chemotherapy, and 11% showed complete response. Not only the response, but also the time for response. We know that is important in metastatic disease. We need a rapid response, but here we know that immune therapy is not good in getting a quick response. We are good mainly in maintaining or duration of response, maintaining this good response. We can see the time to response is 2.1 in both arms, while median duration of response was 9.5 months for the nivo versus 7.3 months for the control chemo alone, and this was significantly higher. And if we look at the patient who had complete response, time to complete response was also the same in both arms, but median duration of response was surprisingly 3.37 months versus 13 months, means it is triple, almost the duration of complete response in the control group. This is the duration of objective response curve. We can see the two curves are nicely separated with median duration of response 9.5 months for the Nevo arm versus 7.3 months for the control arm using chemotherapy alone. And this is a toxicity. Of course, we know that both groups receive chemotherapy gem-cis with the same toxicity as we know. In addition to the new toxicity of the immune therapy, mainly in the form of thyroid dysfunction, mainly hypothyroidism, diarrhea, rash, and pruritus. And this is a health-related quality of life. It is maintained in both arms, and the arm of that used immune therapy was not inferior. And this is the summary of my trial that Evo and Gem-Cis demonstrate statistically significant clinically meaningful improvement in overall survival and progression-free survival versus Gem-Cis alone as first-line treatment for unresectable metastatic urothelial carcinoma, with overall response rate and CR rate was notably higher with the Nevo arm, and the CR rate was nearly double, and the duration of CR almost 3 times longer without any added new toxicity or and also the health-related quality of life was maintained in both arms. So Nevo and Gem-Cis is the first frontline concurrent immune checkpoint inhibitor plus chemotherapy combination to improve overall survival in this setting, with results supporting Nevo plus cisplatin-based chemotherapy as a new standard of care for patients with unresectable or metastatic urothelial carcinoma. I will stop here and thank you so much.
Thank you, Professor Yasser, for this presentation. It's definitely interesting. And as I mentioned, it's finally a positive explanation of we got negative findings before with the Pembro and with Atezo in this setting, and Nevo apparently got the right chemistry or the right adjust for it to positive. As you mentioned, I find it quite interesting. It seems that the positivity it would be very clear if you got like good response completely, and like a good response, then you will get this like tailing of the curve or plateauing of the curve. However, when you look at the beginning of the curve, you find that the drop in both arms are actually quite similar. That's why that the overall survival would seem to be not that big. So it's quite interesting. I think there is will be some competition between the what Professor Ahmed have showed with the men following chemotherapy and the situation where you can combine Nevo plus chemotherapy up front. This is something we should try to answer. I guess we can proceed to another competing study. I hope it will give a chance for other things. So I'd like to introduce Professor Hazem El-Mansi. He is a professor of clinical oncology, Alexandria University, a very close friend of mine and one of our main Casual Club advisors and members. He will present very exciting data that have been showed in the last ESMO for the EV302 and Keynote A39 study for the pembrolizumab plus enfortumab vedotin in the first-line advanced urothelial cancer. So, Professor Hazem, go ahead.
Good evening, everyone. Dr. Amr, I have a question before we start. Why are we speaking all in English? You know, I don't like speaking in English.
You can speak as you wish, Besha. but because we actually promoted this event for an international group from non-Arabic speakers, so I'm just trying to be available for everybody.
Okay.
That's it. But you can speak freely يا باشا. تتكلم عربي زي ما انت عايز.
مساء الخير جميعا. الحقيقة
بالعربي
يعني
حاجة بالعربي.
بس يعني I have a technical issue أنا مش قادر. اوكي. يعني انا حقيقة سعيد ان انا اكون موجود معاكم النهارده، يعني الحقيقة التجميع من السبيكرز يعني is very good and المواضيع متغطيه يعني بتسلسل ممتاز وواضح وجميل جدا. وانا سعيد الحقيقه جدا ان احنا بنتكلم في البلادر كانسر. البلادر كانسر يعني has been away from the new achievements او new medications for quite long time. وكنا دايما بنتكلم على السبلاتين بيزد كيموثيرابي، وعرفنا دلوقتي او يعني شفنا وهنشوف ان يعني it seemed like ان chemotherapy was not the right treatment for bladder cancer، وان هو او especially في advanced bladder cancer، وان التوكسيستي اللي كانت بتيجي منه ما كانتش تساوي البنفيت اللي احنا بناخده. ويمكن انا وانا بسمع كده الديستنجوش سبيكرز الحقيقه اللي قبلي، انا كنت بقول البلادر كانسر دلوقتي بيفكرني بالميلانوما قبل الاميونوثيرابي، وان يعني ما كانش عندنا كلير تريتمنت، او رينال سيل كارسينوما قبل التي كي ايز والسونيتنب، we had treatments but we were not believing in the efficacy. وده الحقيقه بيتغير النهارده الحقيقه احنا هنتكلم على البيمبروزوماب والانفوتوماب بدوتن الاي دي سي في الفيرست لاين ادفانسد اند ميتاستاتيك يوريثيليال كارسينوما. طبعا ده الانسيدنس اوف يوريثيليال كانسر. you have seen it during the slides. 10th most common cancer, 3% of all cancer cases. في Europe it is the 5th most common cancer. لو بصينا في مصر هنلاقيه second in men with 6 among women. والحقيقه ده الانسيدنس بتاعه يعتبر عالي، بس احنا طبعا بنتذكر ان هو نزل في الانسيدنس بتاعه طبعا عشان البلهارزياز والشيستومياز زي ما احنا كنا عارفين في مصر. الحقيقه لما نتكلم على بلادر كانسر لازم نفتكر الاوت كم بتاعه ال 5 years سرفايفل ريت للنون ماسل انفيزيف bladder cancer. احنا we can expect 5 years survival of around 80%. انما لو اتكلمنا على muscle invasive this goes down to 50%. ولكن لو رحنا الحقيقه للميتاستاتيك هنروح disappointing only 5% overall survival, 5 years overall survival, only 5%. And that's why I can consider we did not have an effective treatment for the metastatic urothelial cancer. طيب, what was available for locally advanced or metastatic urothelial cancer as the first time يعني later lines؟ الحقيقه احنا كنا عندنا السيسبلاتين او بلاتينمز، وكنا بنقسمهم زي سبلاتين اليجيبل وسبلاتين انليجيبل. والبيشنتس اللي هم سبلاتين فيت او سبلاتين اليجيبل يعني احنا كنا نتوقع ريسبونس ريت طبعا 50 to 70% وميديان اوفرول سرفايفل اراوند 15%. البيشنتس اللي هم سبلاتين انليجيبل but still carboplatin eligible we can expect response rate 30 to 40% and median overall survival of only 9 months. ويمكن ده اللي احنا شايفينه من الجدول اللي قدامنا. الميديان اوفرول سرفايفل 14 للسيس فيرسس 8 to 9 للكاربو، بي اف اس 8 ل 10 فيرسس اونلي 4 to 6 للكاربو. والحقيقه برضو لازم نفتكر ان up to 50% of the patients with urothelial cancer were ineligible to cisplatin due to the comorbidities او البيشنت frailty patient is frail و cannot tolerate السيسبلاتين. وطبعا كنا بنستخدم another alternative with less efficacy which is the carboplatin. وزي ما شايفين ان احنا كان في اقل الحقيقه في الافيكاسي بتاعته. وبعدين بعد كده دخلنا في الاميونوثيرابي. لو استخدمناه في الفيرست لاين كنا بنلاقي 12 to 19 months of overall survival و 8 to 11 months. لو استخدمناه في السكند لاين بي اف اس برضه around 4 months و 2 to 3 months if in the second line. والحقيقه ده خلانا نستخدمه في البيشنتس who are cisplatin ineligible. هم دولت اللي احنا قلنا ان احنا نقدر ان احنا نستخدم فيهم الاميونوثيرابي. وبعدين بعد كده جالنا في السكند لاين الدافيتنم في اف جي اف ار ميوتيتد بيشنتس. ويعني برضو الحقيقه الريزلتس were not much better as we can see 5.5 months للبيشنتس اللي اخذوا البي اف اس للبيشنتس في السكند لاين اللي هم كانوا واخدين قبل كده ايزر كيموثيرابي الاميونوثيرابي. الحقيقه ما كانتش فارقه كتير. وكمان الاوفرول سرفايفل الحقيقه was not يعني is that promising although yes better than the other alternatives. for patients who previously received يا اما كيموثيرابي او immunotherapy. والحقيقه دلوقتي عندنا الترايل اللي احنا عايزين نتكلم عليها النهارده الانفورتونات بدوتن بلس بامبرلوزماب فور فيرست لاين تريتمنت اوف ميتاستاتيك urothelial cancer. والراشونال for combining EDCs with immunotherapy is quite clear. EDCs بتbind وتinternalize ورelease البيلود بتاعها which exerts direct cytotoxicity. direct cytotoxicity دي بعد ما بتعمل cell death exposure of the immunostimulatory molecules which يعني present a tumor antigen لل T cells and then this activates T cells or natural killer cells to target and kill the tumor cells. This is at the cellular level, and it turns out in the trial to be effective because in our trial, the EV302 or Keynote A39, who had patient population of previously untreated locally advanced or metastatic urothelial cancer, and the patients here were platinum eligible for interferon vedotin, the antibody drug conjugate, and for pembrolizumab as well, but they had to be PD-L1 inhibitor naive, and حوالي 886 patient were randomized 1 into the first arm, the investigational arm of EV plus pembrolizumab, والother arm is chemotherapy cisplatin او carboplatin plus gemcitabine. وكان في dual primary endpoint progression free survival and overall survival. السيرتيفيكيشن الحقيقه كان معمول على حاجتين، على السيسبلاتين eligibility وعلى PD-L1 expression، وكان معاهم the presence or the absence of the liver metastasis. انما كان اهم حاجتين سيسبلاتين eligibility وال PD-L1 expression. لو بصينا على الحقيقه اللي طلعت منهم لازم نبص على survival وعلى الاوفرول سرفايفل، لان هم كانوا the same primary endpoints. they were primary endpoint both of them. هنلاقي الهازارد ريشيو for the progression free survival was 0.45 and طبعا statistically significant, and we can clearly see the difference اللي احنا بنتكلم فيه. hazard ratio is impressive. Number of patients who free of progression after 18 months was really different in the patients who received the infertility and pembrolizumab versus those who received the chemotherapy. And more interestingly, if you look at the subgroup analysis for the progression-free survival, again, this is for the progression-free survival, we'll find that all the subgroups were in favor of the combination of the ADC plus the immunotherapy. يهمنا هنا نبص على PD-L1 وcisplatin with certification factors. هنلاقي ان the CPS less than 10 or more than 10, they were both in favor of immuno plus EDC arm. Cisplatin eligibility either eligible or ineligible, they were both benefited from the investigational treatment. ويمكن تفصيله هنا صغيره. if you look at the PD-L1 expression هنلاقي in patients with high CPS 10 or more had a bit more benefit in favor of the investigational arm, the infertility vedotin plus pembrolizumab, then the low, both benefited, both in favor. But yes, we can see it a bit more for the PD-L1 expression high. Again, this subgroup analysis for the progression-free survival. If you look for the overall survival, again, very impressive data, has a ratio of 0.47. Actually, we're looking to more than double the overall survival when using the investigational treatment rather than the chemotherapy. Was the cisplatin eligible and the cisplatin ineligible benefited? Maybe the cisplatin ineligible had more benefit of hazard ratio 0.43 versus 0.53 for the patients who were cisplatin eligible, but definitely it's almost double the survival for both of them. So it's very clear benefit for this combination over the chemotherapy. If we look for the PD-L1 expression for the low CPS has a ratio 0.44, and for the PD-L1 high CPS more than 10 or more, it's 0.49. Again, almost similar benefit, more than double the overall survival in both subgroups. And if we look here for the subgroup analysis for the overall survival, we'll find again the PD-L1 expression and cisplatin eligibility, you will find the reverse, that the patient with the PD-L1 low had a bit more benefit or from the investigational arm rather than the chemotherapy. And why am I mentioning this? Because we can know here, we can see that there is no significance for the PD-L1 expression in these patients. Either it's less than 10, more than 10, there is no significance. So all the patients will benefit from this combination. If we look for the overall response, we will find 67% for the investigational combination of the EV plus Pembro versus 44% for the chemotherapy, and the patient with complete response were 12.5% only for the chemotherapy versus 29.1% for the patients who received the enfortumab vedotin plus the pembrolizumab, and the difference is clear between them. And then the patients who received treatment afterward, we can see that patients who received chemotherapy, a big chunk of these received maintenance avelumab, and some other patients received PD-L1 inhibitors in the following lines after the progression. So almost more than 56% maybe of the patients who received chemotherapy in the first line received immunotherapy in either maintenance or in later lines. So these patients again received the immunotherapy and the chemotherapy. So when we compare the overall survival of the patients who received the enfortumab vedotin plus the immunotherapy in the first line, and then we go for the overall survival, we find this is better than the patient who received the chemotherapy in the first line, followed by immunotherapy either by maintenance or by in later lines. So it's clear that there is a benefit for using the combination in the first line of enfortumab vedotin plus the pembrolizumab. Again, this is the maintenance, and these are the patients who received it in later lines. If we look for the toxicity for the adverse events, it's different. We can see overall it's okay. It's on the same range. Peripheral neuropathy and pruritus for sure, as well as alopecia, more with is enfortumab vedotin plus pembrolizumab rather than the chemotherapy, and some other toxicity, the classic toxicity of chemotherapy, like the anemia, neutropenia, thrombocytopenia, as well as nausea, probably, and vomiting and fatigue, are more with the chemotherapy. So both are toxic. Probably the toxicity differs from one arm to another, but everyone has its own toxicity. So this led that enfortumab vedotin with pembrolizumab combination was granted accelerated approval by the US and the FDA for the treatment of with testicular serial cancer for the patient ineligible for cisplatin, and probably for
Thank you, Professor Hazem. Very strong data, very strong. Even as a subgroup analysis, there is no crossing of the line at any subgroup. This is, I don't think that we presented today any other study that didn't cross the midline, the line of no difference. This is quite interesting data, and أعتقد الchallenge الحقيقي هيبقى في إنك يعني maybe to answer the questions اللي هو what's next if the patient progressed, اللي ممكن يحصل بعد كده, the load of toxicities. ال ADC في الآخر هو chemotherapy يعني, ففي الآخر maybe you are just rediscovering chemotherapy بطريقة تانية. It's very strong data. I guess we can just proceed the last study, and then maybe we can discuss all together هنعمل ايه بقى بكل الانفورميشن دي, وازاي ننقي وازاي نرتب الحاجات مع بعضها. So it's my pleasure to introduce my dear friend Professor Abdelhamid Fouad. Abdelhamid Fouad is a professor of medical oncology at National Cancer Institute, Cairo. He's gonna talk about precision medicine. So where is precision medicine in bladder cancer? He's going to present the SOAR cohort 2 study, the FGFR inhibitor erdafitinib versus immunotherapy in second-line advanced urothelial cancer. So Professor Abdelhamid, go ahead.
First of all, Dr. Amr, can you hear me?
Yes.
Okay, thank you for the invitation, and thank you for this nice gathering, and that you let me the chance to meet my big brother, Dr. Rafat. Since a long time I didn't meet him. Unfortunately, I'm the only one today that will not represent positive trial. It's a negative trial.
But
And
it
I
is
will-
important.
Yes,
It is
it is,
important.
but don't expect to see separation of curves as Professor Haitham and Professor Yasser and Professor Ahmed.
حضرتك
I
بس هو
will
الصوت عشان الصوت مش واضح يعني حضرتك ممكن اظن ممكن من الهيدفونز يعني لو فصلت الهيدفونز هيبقى أفضل.
say كده أوضح؟ ألو؟
تمام
كده أوضح؟
تمام يا دكتور حميد
I will talk briefly today about the phase 3 SOAR trial, cohort 2. And as we see in the last few years, the field of urothelial bladder cancer is a dynamic field, and we have lots of clinical trials that include new drugs that change the treatment landscape for bladder cancer. The phase 3 SOAR study is a study evaluating the erdafitinib versus pembrolizumab in pre-treated patients with advanced or metastatic urothelial cancer, but with fibroblastic growth factor receptor operation. And this study was presented about 2 months ago in the last ESMO. Unfortunately, still the field of urothelial bladder cancer is represents an unmet need for patients either in the first-line treatment setting or in the second-line treatment setting, as we have seen from the previous studies. In the first-line classified to platinum or eligible, and then either cisplatin or eligible or not, based on the creatinine clearance maybe. And in the first line setting, also we can include immune checkpoint inhibitors, either in the maintenance setting or in the induction phase, either EVO or PIMPO with EV. But although we have all these data, still we are not curing these patients with metastatic disease, and this affects their survival. Upon progression, patients can historically offer chemotherapy, either vinflunine, paclitaxel, but then pembrolizumab alone or plus infliximab vedotin that was moved to the first line nowadays after the recent data. And also we have data about erdafitinib in patients with FGFR alteration. Going to the biology of the tumor, we know that we have target mutations that can be actionable mutations, and FGFR is one of them that is present in about 20% of patients with advanced urothelial bladder cancer, and with 35% in patients with the upper tract urothelial carcinoma. And we have data that these patients are considered immunologically cold tumors with low PD-L1 expression, and expect not to have a good response to immune checkpoint inhibitors. The erdafitinib is a pan FGFR inhibitor. It targets FGFR 1, 2, 3, and 4. And from the single arm phase 2 trial, BLC2001, include patients that with FGFR altered advanced urothelial cancer. We have objective response rate about 40%, median progression-free survival about 5.5 months, and the median overall survival in the second line treatment about 11.3 months, and for a second line treatment, At that time, it represents a very good advance in treatment of such aggressive disease. Then we have the FLOR phase 3 cohort 1 that evaluates a patient upon progression to chemotherapy plus anti-PD-1 PD-L1 inhibitor to erdafitinib versus chemotherapy treatment of choice according to the investigator, either paclitaxel or avenetoclax. And this cohort 1 trial show overall survival benefit in the treatment of arm of erdafitinib with median overall survival 12.1 versus 7.8 in the chemotherapy arm. Then going to a biological question, whether if we add FGFR inhibitor in this subset of patients with FGFR alteration, in subset of patients did not receive immune checkpoint inhibitor in the first line. Did this differ in the outcome, and it can change the treatment sequence? And here the cohort 2 was designed trying to answer this question. And this is our study that we will talk about. It includes patients with metastatic or unresectable urothelial bladder cancer progressed on at least one prior chemotherapy. Patients did not receive PD-L1 inhibitor in the first treatment line, and they have FGFR alteration. Patients, the trial includes 351 patients, and the patients were randomized to erdafitinib versus pembrolizumab, and the primary endpoint was overall survival. And also we have secondary endpoints, PFS and objective response rate, and the safety of both drugs. Going to the baseline demographics and the disease characteristics of the two groups, we can see that both groups are well balanced and include patients with visceral metastasis, especially liver, represent about 25% of patients including in these trials. And also the patients were having low PD-L1, CPS score less than 10, almost 90% of patients in both groups, and CPS less than 1 will represent also 50% of patients in both groups. This is the overall survival curve of the trial. Unfortunately, the primary endpoint was not met, and the erdafitinib and pembrolizumab show almost similar median overall survival. But if we can see the upper half of the curve, we can see a better response to erdafitinib versus pembrolizumab, which can be similarly seen in other trials comparing the pembrolizumab to chemotherapy in other trials. And after that, we can see tailing of the curve, giving the good response to the subset of patients receiving pembrolizumab that respond to the immune therapy. And this can explain the similar median overall survival between both drugs. It was 10.9 regarding erdafitinib versus 11.1 for pembrolizumab. And also in the subgroup analysis, we see the same findings, no difference in any specific subgroup was having better overall survival with erdafitinib versus pembrolizumab. Also, regarding the median progression-free survival, it was numerically higher, 4.4 months in patients receiving erdafitinib versus 2.7 months for patients receiving pembrolizumab. Going to the objective response rate, here we can see a better and higher objective response rate in patients receiving erdafitinib. It reached about 40% versus 21.6% for pembrolizumab patients. But the good objective response rate for patients with irbesartanib, unfortunately, was not durable. It was only for median duration of response was only 4.3 months versus a long median duration of response for the 21% of patients that respond to pembrolizumab. It reached about 14.4 months. And again, this finding can explain that although the patient has better response to irbesartanib, 40% versus 21.6%, the short duration of response can explain there is no difference in overall survival between both groups. Regarding safety, the safety for irbesartanib and pembrolizumab was similar to safety signals reported with both drugs in previous trials. In the irbesartanib group, about 15% of patients discontinued the treatment due to treatment-related adverse events, and about 13.3% of patients had serious treatment-related adverse events with no deaths related to the treatment. And most patients with serious adverse events were manageable by those modifications and those delay or those holds. While regarding especially hypophosphatemia in irbesartanib was seen in the irbesartanib group, and don't forget that hypophosphatemia is a surrogate marker used in the up-titration, surrogate marker for response used for up-titration of the dose from 8 to 9 milligrams for irbesartanib. And other adverse events was stomatitis, diarrhea, dry mouth, and mucolysis and hand and foot syndrome. While in the pembrolizumab arm, we have 4.6% of patients discontinued treatment of pembro due to treatment-related adverse events, and about 10.5 patients had serious treatment-related adverse events, and 3 treatment-related deaths were reported. Regarding the treatment adverse event of special interest, in the irbesartanib arm, the retinal central serous retinopathy was almost in grade 1 and 2. And only we have 2 patients representing about 1.2% having grade 3 central serous retinopathy, and it was resolved by dose delay, and most of patients resumed treatment after that without any problem. And the conclusion of the trial is that the primary endpoint was not met in this trial, because we have similar survival between both drugs. Is observed in patients with metastatic urothelial carcinoma treated with FGFR alteration did not receive anti-PD-L1 in the first time treatment. And irbesartanib has numerically better PFS and objective response rate compared to pembrolizumab, PFS 4.4 versus 2.7 months. And the objective response rate was 50% versus 20.6 months for pembro, but median duration of response was better in a subset of patients responded to pembrolizumab. And here we can conclude that pembrolizumab is active in patients with FGFR alteration, and the outcome of pembro were in line with those previously reported for non-FGFR altered patient metastatic urothelial carcinoma population. And the safety of both drugs were consistent with the known safety profile in this patient population. And irbesartanib toxicity were manageable with those modifications. And here I can finish my presentation, but I have some comments that although patients with metastatic urothelial carcinoma with FGF alteration are considered cold tumor, we can see still immune checkpoint inhibitors are effective. And for patients that respond to immune checkpoint inhibitor have durable response, irbesartanib can represent a good alternative but with shorter median duration of response. And this can be, in my opinion, help to, although not practically changing, but can help in treatment choice in the second line setting if immune checkpoint inhibitor is not given in the first line, to choose the treatment in the second line based on the severity of symptoms. If the patient has aggressive symptoms, we can start with the pattern to have rapid response, and also based on the expected adverse event. But still, we have a lot to know about this subset of patients. Why the patient has actionable targetable mutation, the patient do not show durable response, and why they lose this response rapidly, which is not reflected on the overall survival. And thank you for your attention.
Thank you, Professor Abdelhamid. So it's not very negative, as you said. So there is still a chance for using erdafitinib. So if I understand well, if you allow me, there is a benefit in response you get with using erdafitinib in comparison to pembrolizumab. So basically, if your patient is symptomatic and you want to control symptoms and problems, potentially FGFR would be still the inhibitor would be still the better option for this patient. And if you're using immunotherapy in first line, so this study won't be really a problem because basically you already used checkpoint inhibitors. So that's definitely an issue. It's not an issue. So about toxicities, this is my question for you. And before you answer this, so if anybody from the participants want to, we already have some questions in the chat. So if you have any question, please text it up in the chat. And Professor Abdelhamid, what about the toxicities you get with erdafitinib? How do you look at it? So you see that we should get scared from it or what?
No, you should not get scared because the main two toxicities, as we highlighted, and it was also seen in the cohort 1 trial, that we have mainly hyperphosphatemia because FGFR inhibitor inhibits the absorption or excretion of phosphate in the renal tubule. But we can, it was used as a marker for titration of the dose of erdafitinib from 8 milligrams to 9 milligrams based on the serum phosphate level. And patients that have hyperphosphatemia, I think in the range of 5.5, if I remember good, had better response and better survival when compared to other group of patients that do not have hyperphosphatemia. And also, we can monitor hyperphosphatemia during the treatment of patients, and there is dose reduction schedule based on the levels of hyperphosphatemia if it exceeds 7 or 7 point something, I don't remember exactly the number. Also, we can give instructions to the patient to avoid food rich in phosphate, and the toxicity is manageable by dose delay or dose reduction. And the other common side effect reported is the central serous retinopathy. This is very important for the clinical practitioners dealing with this drug to know about it and to follow the monitoring of the fundus examination during the treatment plan of the patient, and to have a good communication with your ophthalmologist to expect this side effect early. And as we can see from this trial and also cohort 1, most of the patients are, if detected in time, are improved spontaneously after those holiday or those hold and then resuming the treatment without any problem. Dr. Amr.
Great. Yes, yes. I guess it's just simply different toxicities than we are used to. So basically, we got like kind of problems that we are not really commonly see now, but we have to just get used to it. So actually, we have a question.
You have to have an ophthalmologist on board with you. A good ophthalmologist that has to deal with the posterior chamber and to have good retinal examination. This is very important.
Yes, sure. So we have a question for Professor Rafat. So Dr. Asma is actually asking about the experience of using chemotherapy as a substitute for intravesical BCG in high-risk non-muscle invasive bladder cancer. I guess the data from the Keynote 5.7 just started to get the idea of using systemic treatments. However, I think Keynote 5.7 was on like BCG failure. So basically, what do you see? Is there a role for systemic chemotherapy?
Systemic chemotherapy for non-muscle invasive, I don't think there is any evidence for this. If you're asking about this pembrolizumab as immunotherapy, the data was limited to those who are refractory to BCG, so it's not head-to-head comparison. So I don't think it will be any current evidence, because if you look to the toxicity, so we're more and more using immunotherapy in different cancers, and we're now seeing more and more long-term toxicity. So it's not an innocent drug that we can offer it's freely for everyone. So if you look to the BCG schedule, it's only weekly for 6 weeks compared to the pembrolizumab, it's giving every 3 weeks for 2 years, which is a long commitment and long toxicity as well as burden to the health system. So I don't think we will be reaching a point of head-to-head comparison to BCG, and it will only be limited to those who are refractory as an alternative option compared to cystectomy, although still the standard of care is cystectomy.
Yes, I totally agree. I guess that BCG for now is the best we have in this situation, and all will be in later on. And I guess in the ESMO, we got this data from erdafitinib. Actually, it's in a small phase 2 study where it's actually turned out to be positive following BCG failure. However, even the investigator himself was commenting about the toxicities, that it won't be really tolerated, and they are waiting for like intravesical immunotherapy and intravesical erdafitinib, based because they have this high FGFR percentage of positivity in non-muscle invasive bladder cancer. So basically, the systemic treatments in non-muscle invasive, most probably is going to take it and try to put it intravesically. So I guess this is the situation in this arena. I guess we have another question. So Dr. Abeid is actually asking about the driver mutation are not very significant in bladder cancer compared to other cancers like melanoma and lung cancer. So in enfortumab vedotin, beating pembro with high CPS was almost impossible, since more than 90% had CPS less than 10%. So I guess Professor Hazem, if you can answer this question, it's about enfortumab vedotin, though he's talking about beating pembro. I don't know if you can help me with that, Professor Hazem. The correlation between the CPS score and the benefit from enfortumab.
Yes, but a comment about the previous question about the use of the erdafitinib in the non-muscle invasive. The erdafitinib is now under investigation in a clinical trial for intravesical installation, and we have been we've met one of the investigators in this trial last month, and they are seeing that this would be a promising drug to use intravesical. So I didn't get the question of our dear friend Dr. Abeid about the.
He's mainly asking about the CPS positivity, and maybe if I can modify this question into the study was actually separated the patient to CPS 10, more than 10 and less than 10. So if you can get the curve, yes.
Yes, this is,
yes,
as you can see,
this one, yeah. Where you get better with less than CPS 10. So it's a little bit.
Yes, but let's say, okay, when you say better hazard ratio, okay, this is 0.44 versus 0.49. We cannot say that this is really better with the PDL1 low or CPS low than the CPS high. We can consider them clearly, comfortably in the same range, and then we can say here that PDL1 يعني measurement is or testing is not essential or not mandating the
to be tested. Yeah, we don't have to test it.
Yes, we do not have to.
I have a comment.
Yes, Professor Ahmed.
I think this separation is better in the PDL1 negative population due to the effectiveness of the control arm. Chemotherapy is more higher in patient with high PDL1 expression than patient with low PDL1 expression. So the success of control arm in the PDL1 high limits the efficacy of EV plus Pembro in this subgroup.
That's quite an interesting explanation. Yes. Professor Hazen?
If we look for other trial with control arm, look for the number of months for the chemotherapy 16. In the Javelin trial, we have 17 months for PDL1 positive versus 14 or 15 months for PDL1 negative population. So if the efficacy for chemotherapy is higher for PDL1 positive.
Yes, but in this in this group يعني احنا بنتكلم على 16.6 months for the PDL1 high who patients who received chemotherapy, so median overall survival 16.6 versus 15.5 for the patients who received chemotherapy and they were PDL1 low. So let's say they are in the same range. What I can see is that they are in the same range, and then the PDL1 expression is not the main key in the effectiveness of this combination of the enfortumab vedotin plus the pembrolizumab. That's what I can see. I'm not sure if this is answering Dr. Abid questions or not.
I guess that would be fair. I guess that would be fair. So I have a question for Professor Yasser about what do you think about this data? You already presented the data with the Checkmate 901. So it is a positive data. So definitely it supersedes the data with a combination with atezo and pembrolizumab. However, are you satisfied with the outcome? So with what we are having with maintenance AVI and combination enfortumab and pembro. So do you think that it has a chance? What do you think?
Yeah, I think if you look at the three trials that now available for first-line treatment metastatic, we have the chemotherapy and then maintenance. It gives, like Dr. Ahmed said, 22 months since randomization to start maintenance. If you add like 6 months for the chemotherapy, it will end up with 28 to 29 months overall survival. For the enfortumab vedotin plus pembro, it gives like 33 months. But for the Nivo chemo, it's like 21, 22 months overall survival. It's a little bit lower. But I think still could, there is a lot of issues we can discuss in the three different trials. For the maintenance evolumab, as Dr. Ahmed said, we choose the winner, we choose the patients who did not progress on chemotherapy. Those patients do better than the 20% who did not. But in the Checkmate, they include all patients. In the enfortumab, as Dr. Hazen said, yeah, data are impressive, but we have to look for other things like the financial toxicity, the toxicity itself, the neurotoxicity, which might be disabling and other things we have to look at. Other trials using immune therapy in the first line and the metastatic failed, as you said, Dr. Amr, the Pembro and the Atizo. Maybe in treatment they used only cisplatin. We know that cisplatin has a higher immune modulatory effect as compared to other platinum carboplatin. But other trials, they allow patients to receive either cisplatin, or if they are not eligible for cisplatin, they can receive carboplatin. So I don't know which patient do you choose this the treatment regimen if you have the three options are available. But maybe we can look at the patients who get CR, that complete response. They enjoy and maintain a very long duration of complete response. Maybe we can choose based on this feeling results, but still I'm not sure which one is the best or which patient is the best to choose this.
So, Professor Ahmed, so AVI maintenance. So we actually get some quite data. So if you get the perfect patient, so if you start with chemotherapy and you want to choose who's the perfect patient that will receive the maximum benefit from AVI, what would be this patient criteria would be? So
actually, Dr. Amr, I am with the Javelin trial in patient with non-visceral metastasis. I think this is a subgroup of patient need to be investigated better in which is better result for EV trial. Patient with PD-L1 positive population is much higher benefit for PD-L1 negative population, but still all population that cisplatin and platinum eligible are fit to maintain with are fit to be in the Javelin protocols, chemotherapy and then avelumab maintenance. But and especially those population with PD-L1 positive disease and patient with non-visceral metastasis, and we can keep EV for the second line setting or erdafitinib for the second or third line setting. But I think patient with high tumor burden, high visceral metastasis, on especially those with PD-L1 negative, as Dr. Hazem showed the result of PD-L1 negative, I think if available, those population may benefit more with the AV plus Pembro protocol, but we should discuss the quality of life for those population with the AV plus Pembro regarding the toxicity, especially peripheral neuropathy, because this is, I think, this is the main limiting side effect or those limiting side effect for this protocol AV plus Pembro. And those population on progression, I can say that most of them will not fit for any of the available second line treatment, because chemotherapy is still of the choice, but most of those population will be grade 3 or grade 2 peripheral neuropathy, which is the criteria will not fit for platinum after that.
Yeah, yes, I find this very logical actually. The issue with the maintenance AVI is if you get the perfect patients, you will get enough good numbers to compete with the enfortumab vedotin and pembrolizumab combination. However, the problem is that one of the criteria that can get you to this kind of numbers is getting complete response on chemotherapy, for example. However, you are not sure that you're going to get it at the beginning. So how can you choose based on something that will happen when you already started chemotherapy? This is how it is tricky. So if you know which patient will get complete response, so basically, yeah, you will have competed directly head to head with enfortumab vedotin and showed it as competitive at least. But I think the issue is this: is the lack of knowledge. If the patient will get just stationary disease, so I guess maintenance AVI is definitely would be inferior to the ADC immunocombination. Professor Hazem, would you agree on the same concept with me, or are you saying that everything will be that ADC plus Pembro is better than anything anyway? So what do you think?
Well, yes, I presented the trial.
Yes,
but yeah. I can see the other options as well. For sure,
I
I can see the toxicity of the infrastructure vedotin plus pembrolizumab and the financial toxicity or the financial challenge for using both. Yes, but again, how to choose either chemo plus immunotherapy or chemo followed by maintenance? Yes, we're reaching the range of 30 months of overall survival. How to choose is not clear for me. What I see as a benefit for the combination of infrastructure vedotin plus pembrolizumab, that is number one is a chemo-free regimen. Probably you can keep the chemo for a later line if you need it. And number two, that it's all comers, so everyone, so you can know that you started from the first line treatment with the highest till now overall survival and progression-free survival, and the best hazard ratio as you can see when compared with chemotherapy. And that's why I would say if the patient has no contraindication to this regimen, and we have the resources for this regimen, probably I would choose to use it.
Dr.
Yes,
Hazem, you present the subsequent therapy of 302 trial EV plus pembro. You have 30% of population received the protocol is changed after approval of AV maintenance. You have 30% of population of chemotherapy arm received maintenance avelumab in the subsequent therapy. So we will wait for the data of this subgroup as a survivor, because this subgroup means that there is direct comparison between AV plus pembro versus chemo followed by maintenance avelumab, and this may solve the problem as well.
Yes, but this is going to be a post hoc analysis, I guess. Yes. So, but.
And why would you expect that this will have a big difference than the Javelin trial, Dr. Ahmed? It's almost the same patient population, the same treatment.
دكتور احمد يعني عايز يقارن الحاجات دي ببعض. يعني هو من حقنا، يعني هو طبعا للاسف ان السيتنجز اللي احنا فيها نادرا ما بنلاقي يعني هيد تو هيد كومباريزن مع البروتوكولز اللي بتكمبيت. يعني لازم نضطر احنا نعمل try to trial comparison. I guess this is the point. So, Professor Rafat, in the UK, what do you have?
Unfortunately, don't have much. So as I mentioned, we have avelumab. This is approved a few years ago, and this is the standard of care for most of patients. We have nivolumab in the adjuvant setting recently in the PD-L1 positive. So this will cause a problem to allow nivolumab in the metastatic setting if the patient had it in the adjuvant setting. So for those who are presenting as metastatic patients, then you'll be getting the option of either nivolumab chemo versus chemo followed by avelumab. Although I would rather, similar to what Ahmed was saying, I would rather go for the chemo than to be followed by avelumab, because this will allow us better selection of patients who will benefiting more. Because if you look to the data from the nivo chemo, you look that there is a significant drop in the curve, because this patient will not be responding to treatment much, and will just, those who are benefiting from the treatment will have the long-term benefit. So I think giving chemo upfront will allow us a better selection, so better use of resources, because we are in a health system that is paying for all these drugs. So it's maybe different from different countries, but this is my view. We don't have the ADC currently, so we're not in this dilemma now.
Okay, so and it will get more complicated because the data with the ADC will going early on. So this data, all the drugs are going early. So it's no cancer is an exception. Once you get a success, you try to go as early, neoadjuvant, adjuvant, and it will get even more complicated. But I think it's still in the benefit for the patient. So as long as the patient will get benefit, so it's definitely better. Professor Abdelhamid and Professor Yasser, what's your choice? So what would you start with? So Professor Abdelhamid, can you
This
start?
was my question. I'm thinking to ask you this
Really?
question.
So أنا سبقتك يعني أنا اسأل.
in my opinion, cisplatin eligible patients should receive first line cisplatin doublet, and if they are good responders, they should receive, if available, avelumab maintenance, especially if they have PD-L1 overexpression or non-visceral crisis, as Dr. Ahmed mentioned. In the second line setting, if I have, after progression of chemoimmuno, if I have EV, I would rather give it as a second line, or if the patient has FGFR alteration, it will be another option. If I have both options, I can give EV followed by irbesartan as a third line. But if I don't have EV in the second line, if it's not available, and the patient did not have FGFR alteration, so second line will be chemotherapy. This is my view.
That makes sense. So, Professor Yasser, I am an avid advocate for an ADCs because basically I consider them chemotherapy. So they are chemotherapy. It's just a smarter chemotherapy. So I don't want to influence you, but Professor Yasser, how do you see it? So
yeah, I agree. I totally agree with you, Dr. Amr, that ADC is we tried this in other tumors and it's very successful treatment. But here in bladder cancer, I have to look at the data. Yes, we have the strongest data came from the antibody drug conjugate plus immunotherapy, and I would consider to use this. It's not still it's a new treatment. I'm not used to, but in my practice so far, I still use Devlin data. I start with chemotherapy for patients who didn't progress on chemotherapy. I use the maintenance avelumab, but I consider very short time to use enfortumab. I hope this can be afforded by the patients and
yes, so this is a
The
message
problem,
actually.
the problem is the
how much does it cost
financial.
now?
Dr. Amro, what's told us about the AV trial, enfortumab effect or pembro effect or combination? Why in this trial there is no arm of AV alone in order to consider one of the cost drug, especially in this trial. Especially in this trial, the enfortumab number of cycles is opened. So we need to long-term follow-up for those population, especially we have those limiting side effect, peripheral neuropathy, which directly affect the quality of life of the population. This is the first one. Second one, if we combine both data of checkmate plus Javelin trial, I think introduction of immunotherapy early is a mistake because patient didn't respond to chemotherapy, will not respond to immunotherapy, or chemotherapy refractory patient, as we see previously, didn't respond to immunotherapy. So we have 20% of population contaminate the result of checkmate trial. So the checkmate trial only 21% overall survival.
I love this part about contamination. Actually, a lot of the outcomes we see in this data is related to contamination, where a subset of the patient in the study, in the whole study population, is actually driving the benefit. So a lot of the times we are seeing and say, this is a positive study, this is a positive study. This is actually a subset from this patient, from this subgroup is really pushing it. And then we face the idea of subset analysis, and we shouldn't follow the subset too much because the intention was for the primary objective anyway. But I believe that your point is totally valid.
And another point, another
Yeah.
point is the time to introduce immunotherapy. If in Javelin trial, we introduced immunotherapy only after response to chemotherapy. With the control arm, with chemotherapy only, allow patient progress on chemotherapy to receive immunotherapy in the second line setting. So despite that, the separation of the curve is maintained along and significant overall survival. This means that we didn't benefit from immunotherapy if we introduce with chemotherapy based on the checkmate trial. This is number one. We benefit if we introduce immunotherapy after response to chemotherapy. The benefit is less if we delay immunotherapy after progression of the disease. So maintenance treatment with checkpoint inhibitor, I think it is the best position for bladder cancer.
That's an idea. One of the issues, actually, I totally agree. Your word is very logical. However, the idea is that we are now comparing a single study for a situation. And what we know from oncology is that sometimes the data we get from the first study, it doesn't have to like follow if you do again. But with the amount of the new data, I do not expect to have another sequel. So I guess our practice is a final judgment. I guess that we will have to jump in. We have to start using the agents as best as we can, and in the end, we will see what the more effective will prevail eventually. So I hope this is what happens. We already
your opinion, Dr. Amr? What's your opinion about first line and sequences?
بحاولت اهرب اني ما اجاوبش بس اوكي.
Please, I'm waiting for your answer.
Well, I have to discuss with the patient. أنا من الآخر أنا مقتنع in the best situation is patient centered. We have to put the patient in the center of the decision. I know that there is a lot of consideration in real life. يعني في فرق كبير قوي إن أكون بنقي الأدوية دي وأنا قاعد وأنا ما عنديش أي تفكير في الفاينانس في التكلفة والكلام ده. ده في عالم ممكن في الميتينجز، بس في الحقيقه انت بتبقى قاعد مع بني ادم واحد بتاخد فيه قرار هو لوحده. فبالتالي التوكسيستي is a big issue. It can spoil anything. يعني even if you get like the best outcomes in the study and you get severe toxicities that you're not managing it properly, كل الارقام اللي انت كنت فرحان بيها will go from the window anyway. So basically I believe that the ADC, as I said before, is a really interesting drugs. It's a new trend, and I hope it's an effective trend. However, if you do not complement this with knowledge of how to manage toxicities and very good observation, I guess you can have to play it safe. Chemo is still a good option. Maintenance with an immunotherapy is definitely an option. If you want to combine, you can use that. Maybe if you got your own experience and it's working with an Evo, it's fine. If you go really advanced with ADC, I would be really happy to do it, but I need more knowledge about managing it, and we cannot get knowledge except with experience. So I hope for the best, and I guess I don't want to get it any longer on a virtual. Promised not to get it too long. I would really like to thank you based on CGC for all the speakers and all the audience who was held with us till the end. It's really been my pleasure from me and from all CGC board members and advisors, and all of you are actually CGC members and advisors. So basically, we thank you and we thank ourselves. And we thank the audience, and of course, we thank the organizing company, and we thank Astellas for their support for this meeting. And we promise you to be as transparent and as sincere as we can in all our events. So I will all advise you to, invite you to our physical event on Thursday, where we gonna go into a deep dive into clinical scenarios, starting from non-muscle invasive into the second line, but with really cases as we can. By this, I end my words, and I thank you and have a good night and a good sleep. Okay, and bye.
Bye.